So can I have a volunteer to just sit for me here? Thanks for jumping, guys. So come sit face this wall. Okay, we don't want you to give yourself a hug. Okay. Now, I usually like patients hugging their scapula, not their shoulders, because it just gives, because hugging the shoulders does this. I don't have a very good lever. Hugging the scapula does this. I have a nice tight lever. Okay, so to remind you of motion palpation of the ribs rotation, I'm standing on one side of the body, but I will be assessing the contralateral side. I'm going to put my thumb or my finger on the non-articulating tubercles of the ribs, and of course I'd be starting at T1, but for this purposes, I'm going to be starting, say, at around T4, because this is again from T4 to about T12 for the modified cross bilateral. And what I'm going to be doing is I'm going to be rotating my patient toward me. Now, as I'm doing this, Tender? Got it backwards everywhere. Okay, so, and of course you would do that same thing on the opposite side because we assess things bilaterally. Now, so, as you move your patient toward you, what happens is that the ribs on this side translate anteriorly. And so because they're translating anteriorly, the feeling of the non-articulating tubercle should go away somewhat, should lessen, because the non-articulating tubercle is sliding forward. There comes a point, though, where if a person has an issue with rib, instead of it sliding forward and you losing the sensation to some degree, it actually comes into your finger and it feels like it's pushing into your finger. So instead of the rib sliding forward, it's actually moved backwards. So you can relax for a second and we get the skeleton here. May I borrow the table? Okay. Headpiece is neutral or down. Patients aren't like this, but anyway. Okay, so instead of it moving anteriorly with rotation, it has moved posteriorly. So it's like this. It's moved up, and this non-articulating tubercle needs to go back down. So doing the same thing with the cross bilateral, but this time instead of going on the TVP, you're on the non-articulating tubercle of the rib. We'll bring that rib back into place with a nice knee, which is the sound of cavitation, the sound of gas escaping the joint as you are bringing that bone back in place. It is not the sound of bones cracking. Wait, my pet peeve. Okay, no cracking bones. This is the sound of gas escaping, kind of like opening up a can of Coke as you open up that joint space and bring everything back into alignment. Okay, so anyway, I'm not going to go through that whole thing again. All I'm going to show you is, so you've palpated your patient and now you've completely lost your landmark. So again, you would probably move to static palpation in order to find this stuff. Remember how I showed you that if you were to bring your fingers onto the lateral aspect of the spinous process and use your index fingers as that landmark and then adduct all your fingers, your middle finger approximates where the TVPs are. The ring fingers approximates the non-articulating tubercles of the ribs. So I don't want to see anybody sticking their hands anywhere except for the non-articulating tubercles of the ribs. There's really no excuse to be on a TVP when you need to be on an AT. And so you will use your ring fingers this time. See how my fingers are on the non-articulating tubercles of the ribs? I'm exactly there. And if this patient is larger and they have fatter fingers, I will just, use body inches to separate so that I'm precisely where I'm supposed to be. And then you will set up exactly like I just showed you. Okay, so any questions? Corrects for flexion fixations in the thoracic spine from about T3 all the way down to about T10, 11, 12. Like you can even modify this for T1 and T2, honestly. It really is for flexion fixations in the thoracic spine.
Can you name it? What's it called again?
Anterior thoracic.
Thanks.
Okay. So I'm just going to remind you guys of what a flexion fixation means. So I'm going to need somebody to assist me in the motion palpation and then later on the adjustment of the spine. You know what, and I'm also going to turn this table around. on the other side. Thank you. Other side and face the wall. And I'm going to want you to give yourself a hug. And thank you for hugging your scapula. But of course, patients won't hug their scapula, so I just move them anyway. Okay, so here's the reminder. Now, of course, we are working from T1 all the way down because we showed you that with the lumbar spine too. But for the purposes of this assessment, I'm going to be focusing my attention from T3 to about T10. Okay. You put your finger in the interspinous space. You get in close and you flex your patient forward. Okay, don't help me now. Sorry. That's okay. You flex your patient forward. And so as you're flexing your patient forward, what should be happening, you can relax now. What should be happening is that as you flex forward, the top vertebrae moves anteriorly relative to the lower one. And so it in fact opens up, and you should feel an increase of space in between your finger as you're going through like this. There may come a point where upon flexing, you find a segment that when you move it forward, doesn't open. So this is called a flexion fixation, where you feel that that space has been closed, it doesn't open, it's a flexion fixation. So the idea with any adjustment, not just with this or cross bilateral, with any adjustment, is to try to move that segment as much as possible in the way that it's not moving before you give it the quick impetus to keep it there. So in that rotary thing, we rotated it as much as possible before we rotated it back to neutral. In this one, we are going to be trying to flex open the segment as much as possible.
Thank you.
We're gonna flex open that segment as much as possible before giving it that impulse to flex it completely open and therefore restore mobility. Okay, so in order to do this, I'm going to be using my body weight, and I'm going to be using teeter-totters. The teeter-totter is going to be my hand. I'm going to be inserting a flat surface in between that interspinous space so that eventually we can jimmy it open like that. Okay? The flat space can be anything that you want it to be. Many different ways to do this, and I don't care how you do it as long as it's comfortable for both you and your patient. Dr. Dunk's going to show you a bunch tomorrow. I'll show them to you too, but I'm only going to be demonstrating with one. You could make a fist and have the thumb lying flat like this, and it would be that flat surface of the thumb that would be going into that interspinous space that's stuck, and the rest of the spinous processes would be lined up kind of like this so that they're in that little divot created between the thenar eminence and the fingers. Another alternative is to take your thumb away. You take the thumb away so that this is now the flat surface, and so the interspinous space that is stuck goes on that flat surface here, like this, and the remainder of the spinous processes are pillowed in that divot between the thenar eminence and the fingers. The other possibility is you don't need to have a fist at all. You can open your hand like this. The flat surface will be where the interspinous space is, and again, the rest of the spinous processes would be in that space that would have been created if I made a fist between the thenar eminence and the fingers. So instead of this, we're doing this. And the other possibility is the thumb is down, and this is the one that I happen to use, where I'm using my thumb as the straight. The thumb is where the interspinous space is going to go, and the rest of the spinous processes are going to be in that space that would have been created if I had my fingers in a fist between the thenar eminence and my fingers. Doesn't matter, as long as a flat surface is in that interspinous space, and the fingers are in the space that's created between the thenar eminence and the rest. Okay? All right. You're going to lie down on your back. Okay, now, this is a flexion fixation problem. I need to flex my patient as much as possible in order to, or I need to flex this segment rather, as much as possible so that I can initiate motion in that segment because it's not flexing. So I can use the table to my advantage. If I were to elevate the headpiece, which is what I did, all of a sudden I'm inducing flexion in the spine because the head starts tipping forward. Dr. Dunk's probably not going to show you this, and this is optional. I just do this because I like things easier for me. I ask my patients to bend their knees. Why? Because So as soon as you bend your knees, you start doing a C. A C is flexion. You can if you want to. It doesn't matter. Just it's easier for me. Okay. Now, I'm going to find the location. So I've palpated Melanie already, and now I don't know where it was that I found this spot, and I can't tell. I can sit her up, and I can lie her down, and I can't find it. Or I can find it with her lying down. I can induce flexion in the spine with her lying down and induce that motion palpation to find my spot. So I'm going to have you cross your arms, hug your scapula. Does this look familiar? Now, without shifting your body, you're going to roll toward me, so the spine is now exposed. I'm going to put my fingers, where's your spine? There it is. I'm going to put my fingers in the interspinous space, and I'm going to apply a downward pressure on the elbows, just like I did in flexion before, and to feel the opening of the spaces. Tender. And so that was the spot that I had. Okay, so I found the spot without, there it is, without sitting her up, lying her down, it's there. Okay, now I'm going to have you get up just for a sec. Now guys, depending on where you are in the thoracic spine, this depends on what vectors you need in order to totally open up the spinal segment. So I'm going to want each of you guys to get into groups of 2. So everybody in groups of 2 now. One that's facing the table like this, what I'm going to be doing is I'm going to be trying to jimmy it open like this. Okay. So I lost my spot. I don't know where I am. Patient's got the knees bent. The headpiece is elevated. I've already started to induce some flexion. You're going to roll towards me a little bit. I'm going to just find the spot because I don't know where I am. Yeah. Right there. Okay. So can you roll just a little bit more so that these guys can see? Okay. Here's where I am. This is where I'm going to need to be. For you guys, what might work best is if you mark it with your non-adjusting hand, and then your adjusting hand is going to slide under there. Now, you can do this adjustment. You can roll back to it right. You can do this adjustment in many different ways. Because the spine is centered, it doesn't matter what hand you're sliding under there. You can do an ipsilateral contact, meaning I'm standing on this side and it'll be this hand sliding under there. Or you can do a contralateral contact, meaning I'm standing on this side and it will be this hand that slides around and contacts under there. You can have your hands crossed like this, and when you induce flexion, you can do this. You can have your hands, your patient's hands behind their neck, and induce it that way. In fact, that's how Dr. Dunk is going to show you tomorrow. I'm just going to show you how I do it, which is generally a contralateral anterior thoracic. I tend to like contralateral, but you might very well like ipsilateral. I don't care, as long as the vectors are the same. Okay.
And do you always do contralateral even if you're going around? You always do, doesn't matter what hand it is, you always do contralateral?
So generally speaking, my left hand doesn't really do very much for me.
Yeah.
So because my left hand is like pretty much useless, I tend to like using my right hand far more. And so I like the, generally speaking, I like the contralateral adjustment because I feel most comfortable with it. And what I usually do is I will stand on my patient's left side so that when I reach around, it's my left hand just contacting and doing not much else, and it is my dominant hand, my right hand, that's doing all the guiding with respect to my patients. But I could always stand on this side and still stick my left hand in there and have my right hand doing this. And in fact, for a very obese patient where I feel like I can't get my hand contralateral, I will use ipsilateral. I don't care. It's just, I like this one. I use this one the most. You might not like it, but as long as the vectors are the same, doesn't matter what you do. Roll to me. Okay, so I'm finding the yucky spot. I need you to slide down just a little bit more. Okay, that's it. Okay, yeah. And so I'm going to put my contact hand in there so that my thenar eminence, so that the spinous process is on that flat surface, and the rest of the spinous processes are resting in the divot that would have been created if I made a fist like this. Or you could do it like this, I don't care. Okay, I've slid it in, and now I'm going to roll you back to center. Okay. I have to roll her back to center because the spine is centered. So if I roll her this way, I'm not on the spine. If I roll her this way, I'm not on the spine. I have to be centered. Okay, now she's going to breathe in and breathe out because the thorax is going to be used to try to assist me with this adjustment. So you're going to breathe in, and you're going to breathe out, and you're just going to breathe regularly. Now, on the breath out, what I'm going to do, you're just going to breathe regularly. Okay. On the breath out, what I'm going to do is I'm going to push my hand down to induce flexion in the spine. And then what I'm going to do is I'm going to take my sternum and plant it right on my hand. It's like I'm resting on a table. Okay, now I have complete control of Melanie. I can move her wherever I want because my hand is protecting me and my breasts from her and her elbows, and my weight is now guiding her in this movement. So flexion, apply your sternum to the hand. Now, so for those of you guys who are here, you can actually see my thumb, which is my contact. You can see my thumb right here, sort of hanging off in no man's land. I have almost no weight on it. So right now I haven't induced any sort of motion in that segment. I have to, in order for me to do this adjustment properly, I have to feel maximum weight. I have to feel maximum weight over that segment so that it's like jimmying the sucker open. So if there's no weight there, it's not jimmying anything. So because I'm high up, remember, because I'm high up, so roll back, and she breathes in, breathes out, and I plant it. Because I'm high up, it's not just flexion that I need, it is also shoulder shrugging, cephalad traction. So what I'm going to do is I'm going to lunge forward. Shoulder shrugging. Can you see my thumb now? You can't. I have maximum weight over it. It feels like it's so ready to go. Okay, now, time to adjust. So I've done this. I've planted my sternum, and I've moved forward. I've got maximal weight over that sucker. It's itching to be adjusted. Now, because I have had two vectors in here, the A to P vector and the cephalad vector, this plus this equals that. So higher up in the spine, when I do a thrust, my force is going to be about 45 degrees. And it's going to be a push, not a push. It's going to be a drop. So I'm going to bend my knee and bow at the same time 45 degrees. So I'm not pushing this way. Everything's nice and stable. I'm just dropping, but my force is this way. I'm just dropping. If I were lower down in the spine, where I had to do a lot of flexion, but there was no cephalad traction, flexion plus 0 equals this. So my force would be down. So higher up my force is this way. Lower down my force is that way. Okay, enough talking. Let's do it. Roll to me. Okay, roll over. Breath in, breath out, flexion, apply weight, cephalad, thrust. Oh, that was a good one. Okay.